On the show with me today, I have Dr. Dash. Thank you for joining me today, brother, and let's get into it. So,
Yes, sir, James.
what is iodine and why is it essential for us to be consuming some type of iodine on a daily basis?
Well, James, iodine is an essential nutrient, which means that we can't make it. We have to get it in our diet, and we need iodine to maintain body functions and life. The thyroid uses iodine to make thyroid hormone. So without iodine, the thyroid cannot make enough thyroid hormone to maintain thyroid function, and we become hypothyroid, which is a low thyroid condition. With all of the symptoms associated with that, which includes fatigue, weight gain, hair loss. Thyroid controls metabolic function in the body. It controls energy production. It's the thyroid hormone increases the size and number of the mitochondria. Mitochondria are the little energy factories in our cells. We have 1 trillion cells, and the cells that need the most energy have the most mitochondria. For example, the cells of the heart are chock full of mitochondria, so the heart uses a lot of energy to beat. In the brain uses a lot of energy for thinking, so we have a lot of mitochondria there. Muscle cells in the rest of the body have a lot of mitochondria. So thyroid hormone increases the size and number of mitochondria, and also affects mitochondrial function by increasing mitochondrial energy production. So without thyroid hormone, we have no energy. So not only that, all of the organ systems in the body require energy. So the various organ systems stop working. And so iodine is essential for that. And in addition to that, virtually all of the glandular tissue in our body requires iodine to maintain itself. For example, breast tissue will take up iodine and requires iodine for its health. Iodine deficiency is associated with increased risk for breast cancer, as well as gastric cancer and thyroid cancer. Breast cancer being the big one, of course. And there are other lesser disorders of breast tissue that are associated with iodine deficiency. The most common, of course, is fibrocystic breast disease, which is very common in the population, primarily because of iodine deficiency in the population. And it's characterized by little areas of cysts and areas of fibrous change in the breast tissue, which can produce symptoms. The little nodules and cysts can be painful, and it's considered a precancerous condition. Iodine treatment is curative for fibrocystic breast disease. And it also, iodine is also preventive for breast cancer. Those are just a few of the areas where iodine is important for health. It goes on. Our immune system, the cells that function that make our immune system function, those are the white cells. When they draw your blood, the blood has this red color. The red color is from the red cells. But if they spin these cells down, and they can separate the white cells from the red cells, the white cells, those are the immune cells that have different functions, one of which is to engulf bacteria as well as invading organisms that might be in the bloodstream and destroy them. But they can't do that without presence of iodine. So iodine deficiency has a really negative impact on our immune functioning. Our immune system can't work properly without sufficient iodine. Those there are a few areas where iodine is important. Did you have the next question?
Well, yeah, you mentioned a lot there, and I'm a coach. I've been coaching for the previous 12 years, and I remember when I got out of college, we were hooked on this calories in and calories out model. So if you were eating less than you were expending, then you should theoretically be able to lose weight. And I remember that many people would complain about, oh, this is a thyroid issue, or this is a metabolic issue. And I didn't really believe it. So I'm guilty on that part. And I noticed that once my partner Jade, after pregnancy, she's probably going to kill me for mentioning this, but she was complaining about having what she deemed a double chin. And I remember reading some of Mark Starr's work in Hypothyroidism Type 2. I believe that's the name of his book.
Mhm.
He mentions what's called myxedema. Hopefully I pronounced that correctly.
Yes.
And with his pictures, what it looks like overall is just this full body swelling. And I find that it's very prevalent around the face. So with this in mind, and with thyroid hormone increasing the size and number of mitochondria, with many of the or much of the research that's coming out now saying that disease is a matter of mitochondrial dysfunction, could this all be tied back to, it seems that it would be tied back to iodine deficiency. So what causes the iodine deficiency in the first place?
Well, before we get into that, let me show you some pictures of myxedema. Let me just open this. I'm opening this up in a new link. There we go. And these are some pictures from Mark Starr's book. So you mentioned Mark Starr. These are some pictures from Mark Starr's book. Let's see, let me do a share screen. There we go. Okay, can you see these pictures here?
Yes.
So these are from, as you can see, from the clothing. This is from the 1890s. Mm-hmm. Thyroid medicine, you mentioned myxedema. So this is what myxedema looks like. On the left, you have a patient who has myxedema. This person was actually a priest. You can see from the collar, he was a priest. Mm-hmm. And on the right is the same patient after treatment with thyroid hormone. You can see the hair growth comes back, all this puffiness around the eyes, all this, you mentioned a double chin, is all resolved. Mm-hmm. So this is what myxedema is a peculiar thickening of the skin with a gelatinous substance, and it involves not just the face but the whole body. Here's another one, and you can see all this skin thickening and puffiness before treatment, and then after treatment, the patient looks a lot younger. So in terms of an anti-aging treatment, this could be the ultimate anti-aging treatment with thyroid hormone for people who have myxedema. So you can get this appearance from hypothyroidism or low thyroid deficiency. And the thyroid deficiency can be caused, that one of the causes is iodine deficiency. The thyroid requires iodine. If it can't get, if there's no iodine coming into the diet, then the patient becomes myxedematous like this from a low thyroid condition.
Now, would you need to take the thyroid hormone medication, or would you be able to resolve this strictly through iodine supplementation? Because we were able to resolve it.
Yeah. Well, if the hypothyroidism, if the cause is iodine deficiency, then yes, iodine alone will resolve all of those symptoms that you're seeing. One of the symptoms being that myxedema look, which is a very characteristic appearance that is sort of gives away the underlying hypothyroidism. There are other causes of hypothyroidism which we can touch on. Another very common cause in the population is autoimmune thyroid disease. The most common being Hashimoto's thyroiditis, which was first described by a Japanese surgeon by the name of Hashimoto around 1912. Looking at surgical specimens, thyroid histology in surgical, and thyroids removed surgically, and he found lymphocytic infiltration. Remember, the lymphocytes are the immune system, so that's an immune attack on the thyroid gland, and so that's one of the most common, and it's characterized by elevated thyroid antibodies, which can be measured on blood testing. The two antibodies are called TPO, which stands for thyroid peroxidase antibody, and the other one is thyroid globulin antibody. The treatment is to give the patient thyroid hormone, which then calms down the thyroid gland and treats the hypothyroidism and suppresses the TSH. We typically see improvement in antibody levels, which decline over time. Another useful treatment is selenium, which many of these patients with autoimmune thyroid disease are selenium deficient. Selenium is a mineral required for the antioxidant system in the thyroid. So without selenium, these patients will get worse. So iodine is important in a lot of different ways. One of the thoughts which we talk about in my book, I'm going to just show my book here, plug my book, Natural Thyroid Toolkit, if that's okay with you.
Of course.
And we talk about iodine quite a bit, and also autoimmune thyroid disease in the book, which is available on Amazon. So in terms of, big question is, well, what is the etiology of autoimmune thyroid disease? And one theory, which I think is the most compelling, is that iodine deficiency is a direct cause of autoimmune thyroid disease. How does that happen? Iodine deficiency causes elevation of TSH. TSH is the hormone made by the pituitary gland that stimulates thyroid function, and it compensates for the iodine deficiency by raising TSH, which then increases the activity of the sodium iodide importer, which is the little vacuum machine which allows the thyroid to suck up the iodine. So that's the little protein machinery which takes up iodine from the circulation and concentrates it within the thyroid to a concentration 50 times greater than the concentration in the blood, circulating blood. So the TSH will increase the uptake of iodine by the thyroid, and hopefully compensate for the reduced iodine availability in the diet and in the bloodstream. What happens then is the TSH also increases hydrogen peroxide generation, which is required for the use of iodine in the production of thyroid hormone. There's a process called organification, which requires the hydrogen peroxide as an oxidizing agent that converts the iodide, which is ionic iodine, to molecular form, which is called iodine. And the iodine, once the hydrogen peroxide and that's where the TPO enzyme comes in, which is important for that process. It's called organification. That's the process of combining iodine to thyroid globulin, which is the backbone protein, which then becomes, once the iodine is attached, then that becomes thyroid hormone. So what happens is, when we have iodine deficiency, that the thyroid compensates by trying to increase the uptake of iodine. It does that by increasing TSH levels, which that comes from the pituitary gland in the brain. TSH goes up. That stimulates the vacuum pump machinery that concentrates iodine. But it also stimulates hydrogen peroxide production. Remember, hydrogen peroxide is oxidative. It's you can go down to the corner drugstore and you can buy hydrogen peroxide in a little bottle. It's used as a cleaning agent and as an antiseptic. You can clean your little scrapes and injuries with hydrogen peroxide. You can use it. It's also used as a general cleaning agent for. You can clean your dishes. You can clean instruments, medical instruments. It's an oxidizing agent. available over the counter. But hydrogen peroxide is also produced by the thyroid gland to make thyroid hormone, and it's produced at a particular location. It's called the apical membrane of the thyrocyte. That's the same location where the iodine is oxidized by the hydrogen peroxide, and where the iodine is attached to the thyroid globulin. It's all performed by the TPO enzyme. So right in the vicinity of the hydrogen peroxide, you have the two little proteins. One is the TPO enzyme, which is a protein, and you also have the thyroid globulin protein in direct vicinity at the apical membrane of the thyrocyte. So when there's excess hydrogen peroxide production, that hydrogen peroxide can damage those two proteins. The damaged proteins then become antigenic, meaning they're damaged, so they're now considered foreign by the immune system. And we now have autoimmune thyroid disease. Our immune system recognizes the foreign proteins and triggers on them and develops an immune response. And that creates autoimmune thyroid disease with elevated TPO and thyroid globulin antibodies. Those are the antibodies that we can measure in on the blood test. So that's considered one of the theories for the etiology of autoimmune thyroid disease, Hashimoto's being the most common, which causes thyroid destruction over time, and hypothyroidism requiring, eventually it's bad enough to require treatment with thyroid hormone. The other major autoimmune thyroid disease is called Graves' hyperthyroidism, which does the opposite. It causes hyperthyroidism, meaning elevated thyroid function, which is called thyrotoxicosis. Thyrotoxicosis, which symptoms are the patient rapid heart rate, sweating, weight loss, just the opposite of hypothyroidism. There's too much thyroid being produced by the thyroid gland, and that's because the antibodies produced in Graves' disease are antibodies directed at the TSH receptor, and these antibodies stimulate the TSH receptor in the thyroid gland, which then increases thyroid hormone production uncontrollably, which then results in super high thyroid levels. In the olden days, before the invention of anti-thyroid drugs, the main treatment for Graves' disease was iodine. Iodine was one of the first drugs introduced into modern medicine back in the 1800s, and so the use of iodine was the only medicine available, and so it was very commonly used in very large doses by the early medical practitioners. And one of the very first case reports that appeared in the medical literature was a patient who had hyperthyroidism, a young female in Paris, and a French doctor intended to, she had a very rapid heart rate when he examined her, and he intended to treat her with digitalis, which slows the heart rate, but he made a mistake and he wrote the prescription for iodine, which is, which was one of the common drugs used for other things. And so the patient was given a very large amount, roughly 50 milligrams to 70 milligrams of iodine. Remember, the RDA for iodine in the United States is 150 micrograms. So she got, a magnitude, many magnitudes greater dosage. The French doctor came back in the morning and her pulse rate was totally normal. So he realized his mistake and continued the iodine, and she did well with the iodine treatment, which slowed her pulse rate. And that was the treatment for Graves' disease, hyperthyroidism. And we're even to this day, in the United States, hospitals have liquid iodine on their hospital formulary in their pharmacy to treat patients with hyperthyroidism who need thyroid surgery. They can use the iodine, liquid iodine, to as a treatment to slow down their thyroid function. So iodine has been around for a long time. Iodine deficiency globally is a major global health problem, and there are organizations like the World Health Organization. Lately they've received a lot of bad press about the vaccination issues. That's not the only thing the World Health Organization does. A big chunk of their budget goes to testing and treating iodine deficiency, and they do that using the spot urine for iodine test, which is available at the two major national testing labs in the United States. Quest and LabCorp both do the same test, the spot urinary test. And then the World Health Organization, what they'll do is they will give iodine supplements to the entire village. It's mostly in third world countries, Africa, Southeast Asia, Malaysia, where you have people, living in poverty, at poverty level, who are iodine deficient. So this is important to treat iodine deficiency globally, because iodine deficiency in the women of childbearing age, the pregnant mother, is globally the most significant cause of fetal mental retardation in the developing fetus and childhood. That's another major benefit of iodine supplementation, and which was done in the United States in 1924, based on the research of David Marine, who recommended introducing iodine supplements to school children in Michigan. That was where the initial testing was done. What happened was the little children in Michigan had goiters. Iodine deficiency remember we talked about the increase in TSH, which the TSH will stimulate growth of the thyroid gland itself, which increases the size and causes the goiter in little kids. So they found that the introduction of the way they introduced iodine supplements to the children and later to the entire population of the United States was through iodized salt. So when you go to the grocery store, there's an aisle there where they have the salt, and remember, there's the blue cylindrical container with the girl with the umbrella. Remember that? Morton salt. Yeah. Well, there's a little label that says iodized salt, and they required the manufacturers required to put that label on there to tell you if it's iodized. Now you have salt, other salt companies, it's primarily sea salt. It's not which are not iodized, and those will also have a label that says this salt does not contain iodine, an essential nutrient. So they're required to tell you if it's iodized or if it's not iodized. So none of the sea salts in the past were iodized. The pink one is the Himalayan sea salt. Everybody knows about that one. That's very popular. I think it's the pink color. People like that, that pink color. And so Morton, I think, I would guess that they were losing market share. So Morton, in order to regain their market share, came out with an iodized sea salt. So if you want sea salt that's iodized, Morton salt has one. So in 1924, they introduced iodized salt in the United States. Other countries, European countries and South America, did it later, but most of the other industrialized nations have introduced iodized salt as well. so the big question is, well, the other thing I have to tell you about the introduction of iodized salt. Number one, there was an increase in mortality shortly after that was done, and that was because of there were certain people in the population who harbored autonomous thyroid tissue. It's called an autonomous nodule, and that's one cause of iodine-induced hyperthyroidism, where they become thyroid toxic when they take iodized salt. And some of those people will die from it if they don't. Remember, this was back in 1924, 1925, and they didn't really have good medical treatment for that. The other thing that you might be interested to know is that the United States military tested all new recruits with IQ testing. So all recruits, and they had testing every year, and the results were published, public information. So with the introduction of iodized salt in 1924, the age to enter the Army was 16. So they tested all 16-year-olds. So if you add 16 to 24, you get 1940. So in 1940, they noticed that the average IQ in geographic areas of the United States that are known to be iodine deficient, the average IQ in those military recruits increased by 15 points. And how could that happen? Well, what was the explanation for that? Well, remember, if the mother is iodine deficient, then the developing fetus doesn't get enough iodine to have good thyroid function. Development of the brain and nervous tissue requires good thyroid function, good iodine intake. And so in 1924, when they introduced iodized salt, all of those pregnant mothers had sufficient iodine in their diet so that the fetus, the developing baby, could have a good iodine level and good neural development, good brain development, and increase the IQ by 15 points starting in 1940, which goes back to the introduction of salt, the iodized salt 16 years previously. So, iodine deficiency is a big problem in mothers of childbearing age, because that leads to not only mental retardation, but their abilities in school, cognitive function, school performance declines because their mothers were iodine deficient during pregnancy. So let's get back to
the cause of the iodine deficiency. And before we move on to that, so with the iodized salt, it's, to my understanding, I've read Dr. Brownstein's work, were they actually consuming enough iodine from that salt alone?
It was enough to raise the IQ of military recruits by 15 points.
Yeah. So
I think that's a pretty good result. I think the iodine deficiency in the United States has actually gone up 50% over the last 20, 30 years. And I think it's because people are just not using iodized salt. Or remember, if the iodized salt sits around for a long time, the iodine is volatile. So you can lose the potency of the iodine that's in the salt. I think if the other thing that helps a lot in terms of iodine for childbearing women of childbearing age is if virtually all obstetricians will recommend that they take a prenatal vitamin, and all prenatal vitamins include the RDA for iodine, which is 150 micrograms. Some of them maybe have a little higher. So at least they're getting 150 micrograms in their vitamin, and then if they're using iodized salt, they'll get another 50 to 100 micrograms a day from the iodized salt, depending on how much they're using. so the big question is, well, we have iodized salt. Why do we have iodine deficiency? Well, I don't know, but I would guess that part of it is doctors will tell their patients in general, don't use salt. Salt is bad for you, causes high blood pressure. So you have a vast number of people who are avoiding salt, which has the iodine in it. So the American diet is iodine deficient without the use of iodized, and iodized salt is the major source of iodine right now in America. You can also get iodine, if you look at the Japanese diet, they have a very good iodine intake in their diet, and the reason for that is the Japanese diet includes seaweed. Seaweed is very high in iodine, so go to the health food store, you can buy dried seaweed to add to your food. If you go to the Japanese restaurant, you get the sushi or the Japanese food, or even Southeast Asian food, Korean food, Thai food. We have a restaurant called My Thai, which is food from Thailand, and that's high in their food is high in iodine. So we use the spot urine test to check for iodine level on our patients routinely. We do that on everyone, and so I'm looking at the lab results on a young man in my office, and I said, "Wow, you have really great iodine level. And do you eat Japanese food or Asian food?" And so he says, "Of course I eat Asian food. My wife is Asian. She makes all the food." So if you're eating Asian food, then you're probably getting plenty of iodine.
You mentioned the anti-aging before. Maybe this is why Asians tend to look youthful even into their old age.
It
Perhaps.
It's that's a brilliant observation, James, and I'm going to check that out to see if you're right, and I'll get back to you.
Maybe we'll see.
But some people look younger. I showed you those two pictures of the myxedema on the left and the treatment with thyroid hormone on the right, which it's you can put that into Google Images, and people will in general post their images before and after they started their thyroid pills, and people are proud of their picture, they do little selfies with their cell phone, and they will post them on Facebook and other places, and you can do an image search, and they'll pop up, and you can see hundreds, thousands of people before and after thyroid, and it's remarkable before and after thyroid pills. But it's a very characteristic, distinctive look. For example, there was a newspaper, there was a television journalist by the name of what was his name? I can't remember right now, but he had his head looked like a beach ball, and he looked like there was a valve, like you see on an inner tube, and somebody was just pumping up his head, and his head was just expanded like a beach ball being pumped up. And he, if we go back to, let's see, let me see if I could find that. But anyway, he had the thyroid condition. He was hypothyroid, and the other one of the other symptoms of a low thyroid condition is those people tend to develop coronary artery disease, heart disease. That was first described by Broda Barnes, who is a thyroid specialist, wrote the book on thyroid back in the 70s. And Broda Barnes studied in a town called Graz, Austria. This is in his book. He went there every summer, and the reason why he went there was because it was an iodine deficient area in the mountains in Austria, and a large percentage of the population had a low thyroid condition. And so what he found was many of them, and the other thing that he was interested in was the local government mandated that anybody who died in Graz, Austria, Graz, had to have an autopsy. So all those autopsy records were preserved and public information. So they had information on a cause of death for everybody who died. And so what Dr. Broda Barnes found was the people in Graz, Austria tended to die of an early age of infectious disease. And that's because hypothyroidism is associated with susceptibility to infections. A lot of it was tuberculosis and other infections. Their immune system's not functioning well because we need iodine and thyroid hormone for good functioning of the immune system. Then once antibiotics were introduced, 40s, what happened was the people were no longer dying from infectious disease because they had antibiotics, but instead they would go on to live another 10, 20, 30 years, and they would die at an early age of heart disease, coronary artery disease, where they developed atherosclerotic plaques and atherosclerosis of the coronary arteries. And so Broda Barnes went on to write another book called The Riddle of Heart Attacks Solved. And the riddle was solved by the explanation that the low thyroid condition is associated, actually is a cause for accelerated development of coronary artery disease. And since the 70s, when he wrote his book, since then, there's been a lot of new research that showed, you know what, he was right all along. One of which was the Hunt study, which was done in Scandinavia, showing that risk for heart attack is directly related to TSH in the normal range. So the higher the TSH, meaning low thyroid condition, it's inverse with thyroid function. Higher TSH means lower thyroid function. The higher the TSH, the greater the risk for heart attack. Lower the TSH, the less risk for heart attack. And there's a chapter in the book, which talks about risk for heart attack, and it's linked to the low thyroid condition. And we talk about Broda Barnes quite a bit. Broda Barnes was also the first to use the basal body temperature as a indicator, as a marker for low thyroid condition. Because remember, the thyroid level controls metabolic rate. Metabolic rate controls body temperature, which, when the mitochondria in our cells make energy, one of the byproducts of energy production is heat. So as we make energy, we make body heat. For making less energy at the cell level, then we have less heat, our body temperature goes down. So Broda Barnes, we use that all the time. We use that on a regular basis. The basal body temperature is very useful. And I find that in general, that's true. Nowadays it's easy to check temperature. You have these little electronic gadgets that I have one that's infrared. It bounces a little infrared light off the forehead, and it goes beep, and it tells you the body temperature. So it's easy to do that. And what I found is we're finding low body temperature in people with a low thyroid condition. Broda Barnes was right about that too. So
and that's huge. The fact that it's linked to coronary artery disease, and then people are chasing after cholesterol, or they're going on to all these statins when they may have undiagnosed hypothyroidism. So we have some of the telltale signs, which would be very easily detectable within the face. One of them would also be temperature. So I've heard that if your hands or feet are cold, if you're cold all the time, then it's very likely that you are hypothyroid.
Well, just to continue that thought, the foreword to my book is written by David Brownstein, who's he's a colleague and a mentor to me for over the many years. And if you listen to Dr. Brownstein's many talks that are on YouTube and Rumble and BitChute, videos of his talks, he sometimes talks about his dad, who had heart disease, and he was under treatment, different treatments over the years. Nothing really seemed to help. And then eventually, after Dr. Brownstein finished medical school and started medical practice and learned about thyroid, he started his dad on thyroid medication, and it cured him. He was able to function again, without having chest pain on a frequent basis. And
life-changing.
Yeah, so he has direct experience with his dad, using thyroid hormone in a patient with chest pain, angina, and symptoms of coronary artery disease long term. So that's personal testimony from Dr. Brownstein about that. And I think thyroid hormone is very beneficial for the patient with coronary artery disease, and we're fairly liberal with its use. In my patient population in our office, in the patients that we've treated with thyroid hormone, we've virtually seen no heart disease. It's and we do follow the coronary calcium score. One of my other books is called Heart Book, which came out before the thyroid book, and that book covers the coronary calcium score and how it's useful in medical practice. So we do follow the calcium score is a highly accurate and significant predictor of heart attack risk over the next few years. So the best score, of course, is 0, with indicating no calcification. The score can go up into the thousands. If the score is over 1,000, that indicates very high risk for heart attack over the next few years. And so what we found is the people who are taking thyroid do much better, and we see no progression of calcium score in that group. And there are a number of studies looking at calcium score and correlating that with thyroid hormone levels. And what they found is people with low thyroid hormone levels tend to have higher levels of calcium score, which goes along with more advanced coronary artery disease. So it's all, the connection with heart disease is real. Broda Barnes was right. He found the connection back in the 1970s, and we have an entire chapter in the book devoted to the link between low thyroid condition and heart disease.
Now, you mentioned thyroid hormone, and I have your book. I've read it. So you prefer, based off my reading, natural desiccated thyroid as opposed to something like levothyroxine, Synthroid. What would be the reasoning behind that?
The levothyroxine is T4 only. So when it comes to production of thyroid hormone by the thyroid gland, there are 2 components of thyroid hormone based on the number of iodine molecules attached to the thyroid globulin. So if we have, thyroid hormone, first of all, the backbone is 2 tyrosine molecules. Tyrosine is an amino acid which is naturally occurring in the body. So 2 tyrosines can hold 4 iodine molecules attached to it, and that's it's a very simple molecular structure. So T4 means the 4 iodines. T3 means that one of the iodines have been removed. There's a enzyme system called the deiodinase, which is a medical term for removing an iodine. So there's an enzyme that does that. and converts T4 to T3. T4 is not the active form of the hormone. The active form is T3. So in order to get the hormone that's working, doing the right job, the deiodinase system has to function properly. Which then again, we talked about selenium. The deiodinase system is a selenoprotein. It contains selenium. So selenium deficiency will cause a inability or reduced ability to convert T4 to T3. There's also genetic variations in the population where there's a mutation in the production in the deiodinase enzyme. Those people have difficulty converting from T4 to T3 as well. So it's about 20% of the population has difficulty converting T4 to T3 due to one of those two reasons. The other 80%, they do fine with the T4 only thyroid medication, which is the levothyroxine. There are a number of generic versions of levothyroxine. About 20% of people don't do well. They're having trouble converting it to T3. Those people do much better on a natural desiccated thyroid, which contains both T3 and T4. This natural desiccated thyroid is desiccated means it's dried tissue, and it's an animal thyroid. Their very first desiccated thyroid preparations, came from other animals, sheep, cow thyroids. The modern version comes from a pig thyroid glands. So desiccated pig thyroid is what goes into the commercially available thyroid pills, which are available at the corner pharmacy. Walgreens, CVS, all the corner pharmacies carry natural desiccated thyroid. And the two manufacturers available in the United States currently are number one, Armour. The Armour has been around for a long time. And then the second one is NP Thyroid, which is made by a company called Acela, which is located right here in Florida. The Acela, I think, is a little better. It's preferable to the Armour because it has less fillers. But they both are about the same. They're about equivalent. They both have the main ingredient is natural desiccated thyroid, and they have tablets of different sizes. The standard tablet is a 1 grain tablet. The 1 grain tablet contains 38 micrograms of T4 and 9 micrograms of T3. So a 2 grain tablet would have double that. The usual dosage depends on body weight and what the underlying thyroid function is. So, for example, if a patient has had a thyroidectomy, they have no thyroid function of their own, they have no thyroid gland, they'll need a higher standard dosage than, say, a patient with Hashimoto's who might have 50% thyroid function. So we determine dosage by starting off at a relatively low dose and then gradually working our way up, and then rechecking labs and checking with the patient how they're doing clinically. We usually check labs at 6-week intervals and check with the patient every 3 weeks, something like that. And eventually reach the point where the patient's on enough thyroid dosage where, their symptoms of a low thyroid condition have all resolved. The lab reports may show at that point a suppressed TSH, which is perfectly acceptable for the natural desiccated thyroid medication protocol. The endocrinologists and primary care physicians are upset if they see a suppressed TSH below the reference range. And we discussed that quite a bit in the book. You may have noticed there's a chapter on that.
Yep.
Which is entitled TSH Suppression, Risks and Benefits. So we go through that quite a bit in the book.
What lab are you looking at? Because I know you're pretty adamant about how many doctors are just looking at TSH alone. So what other labs are you looking at?
Yeah,
And
the lab panel that we recommend is the TSH free and the free hormone levels, free T3, free T4. And this is what we do routinely on everybody: TSH, free T3, free T4. And we also look at a reverse T3. There's a chapter in the book entitled Reverse T3, Useful or a Waste of Time. And the reverse T3 is useful when you have everything, all those other results. It's useful because it gives us a window into the deiodinase system. If the patient's taking levothyroxine and they're not doing well, they have lingering symptoms of a low thyroid condition, hypothyroidism, while on levothyroxine, usually the labs will show the reverse T3 a little higher than it should be, and it'll show the free T4 higher and the free T3 lower than we usually see, indicating poor conversion. Instead of converting the T4 to T3, it's being converted to reverse T3. So that's a little window into the deiodinase system, which means, what this patient's going to do much better on a thyroid medication that contains both T3, T4. It's called combination T3 and T4. There are two ways to do the treatment with combination T3 and T4. One is, as we discussed, the natural desiccated thyroid, which contains both. And the other way to do it, which a lot of endocrinologists and primary care doctors are now getting on the bandwagon with combination therapy, the patient is already taking levothyroxine, which is T4. They will add Cytomel, which is T3, available at the drugstore. They'll add a small dose of Cytomel to the levothyroxine, and that will give a similar combination therapy. And so those are the two ways to do it. You can use natural desiccated thyroid, or you can use combination of levothyroxine with Cytomel. I know your interest is mostly in the iodine. The other thing about iodine that we want to mention is iodine is useful as a breast cancer preventive and also as a treatment for fibrocystic disease, as I mentioned earlier. So those patients will take a larger iodine dosage, the RDA being 150 micrograms. The iodine tablets that we use are called Ioderol, and those Dr. Brownstein worked on an iodine project with his mentor, Dr. Guy Abraham, and Guy Abraham is the inventor of the Ioderol tablet and owns the company. Those tablets are 12.5. They have two tablet sizes. They have a 12.5 milligram tablet, which is roughly equivalent to the iodine intake in the Japanese diet. Depending on how much seaweed they're eating in the Japanese diet, you can reach 12 milligrams. And then they also have a 50 milligram tablet, which is used by the women who are interested in treating breast cancer, or say they've had breast cancer, they've had treatment, they want to prevent recurrence. They'll take the larger dosage. And also the larger doses, the 50 milligram is used by women who want to treat their fibrocystic breast disease. Those are the two major categories. When starting a high dose iodine protocol like that, number one, it's good to check iodine levels in advance. We use the spot urine. Dr. George Fletchus, who worked with David Brownstein on the iodine project, started a lab called Halaka. I think it's called Halaka or Hakala lab that does the 24-hour urine collection for iodine. And so that's available. That type of a test is available. We prefer using just the spot urine, which is just one sample, which the patient could do. They're going to the lab anyway to have their blood drawn, so they can provide a urine sample at the lab at the same time. Makes it more convenient in terms of just one visit. They don't have to do a 24-hour collection. So when starting the high dose iodine, number one, do preliminary testing with the spot iodine. Also, we routinely check, routine lab includes full thyroid labs that we just discussed. We also check thyroid antibodies, the TPO and thyroid globulin, routinely on everybody on their first panel. And so for people with normal thyroid function who do not have autoimmune thyroid disease, they do well with the high dose iodine protocol, which can be one 12.5 milligram iodoral tablet, or some of them who will actually take a 50 milligram tablet, the higher dose tablet. But the one thing that we have to be careful of, and that we remind everyone of, is when starting a high dose iodine protocol, we have to be careful of a thing called dermabromism. And what dermabromism was described over the years, back in the 1930s, 1940s, there were a lot of medications that contain bromine, and there still are. We still have a lot of brominated medications. We also have brominated soft drinks. For example, Mountain Dew. It has bromine in it. It's called BVO, brominated vegetable oil, which, by the way, is banned in a lot of other countries. It's still accepted in the United States. So we're getting bromine from medications. We're getting bromine from soft drinks. There's also bromine in our environment. For example, the flame retardants in furniture. If you look at the label on your pillow and mattress, it says this is treated with a flame retardant. That's brominated hydrocarbons. So we're getting bromine every time you lie down on your mattress. You're absorbing bromine from it. There's bromine in furniture glue. There's bromine in various various chemicals that are sprayed on our fruits and vegetables. They're used as fungicides on fruits and vegetables. So we're consuming bromine pretty much 24/7. So the body accumulates bromine. Bromine is toxic. It's a red, oily liquid, and excretion of oils comes out in the oil glands at the base of the hair follicles in our body, located in the skin. So when the body gets rid of bromine, it tends to come out in our skin, is excreted by the oil glands, and produces an mysterious itchy skin rash. Patient goes to the dermatologist, they scratch their head, they have no idea what it is, but they always give topical steroids anyway. And that's dermabromism. So how do we avoid the dermabromism when we start high dose iodine? And why do we get worsening dermabromism? It's because iodine, bromine, and other halogens like chlorine and fluoride, when we start high dose iodine, the body will then excrete the other halogens. Bromine, fluorine, chlorine will then be excreted. And so the bromine will come out in the skin, cause the mysterious skin rash. We can also get other symptoms of dermabromism, which are quite lengthy. You get headaches, metallic taste, things like that. Gastrointestinal disturbance. So how do we avoid dermabromism? And the solution to that is table salt. And Dr. Brownstein recommends a good quality sea salt rather than the processed salt. Good quality sea salt, half a teaspoon twice a day, in water or mixed with food. And how does that work? Well, the salt is sodium chloride. The chlorine and bromine are halogens, so they're in the same column of the periodic table. They have similar properties electrically. In solution, they can exchange. So the sodium chloride will now exchange and become sodium bromide. Sodium bromide is no longer an oily liquid. Now it's water soluble and it can be excreted by the kidney. So we're able to pee out all of the bromine instead of the bromine accumulating in the skin. We can eliminate it in the urine, and that's how we can avoid the dermabromism. by using table salt. That's described quite in the veterinary literature for cats and dogs, because in veterinary medicine they have a lot of bromine containing medications for your pet dog and cat, and so that's a big problem for the veterinary medicine people, and they will give intravenous salt, sodium chloride. So the dermabromism is important to keep that in mind when first starting the iodine, and you want to continue the table salt, the sea salt, during a high dose iodine protocol as it continues. So the other question you wanted to ask, of course, is, well, what about the safety of iodine? Iodine is one of the safest minerals that we have. It's taken in huge doses by large chunks of our population, given out by doctors. Doctors will prescribe a medication called amiodarone. The cardiologists use it as an anti-arrhythmia agent for people with cardiac arrhythmias. Those tablets contain 75 milligrams of iodine each, and about 7 milligrams will be released into circulation by each tablet on a daily. If they're taking one tablet, that's 7 milligrams a day of iodine they're getting. There's another medication called SSKI, supersaturated potassium iodide, also very large amounts of iodine that's used for obstructive lung disease. It's prescribed by pulmonologists very commonly. The government will hand out to the general population 130 milligrams of potassium iodide if there's a nuclear power accident with release of radiation at your local nuclear power plant. So that's 130 milligrams to the whole population. So iodine is one of the safest. Having said that, you can get adverse side effects in people with thyroid disorders. The two, as I mentioned, the first one is autonomous thyroid tissue, and that's called autonomous thyroid nodule. There's a chapter in the book devoted to that. Those are people with either a single autonomous nodule or multiple nodules. It's called a multinodular goiter. One of them turns into an autonomous nodule. Those people will become hyperthyroid with iodine intake, because the autonomous tissue means that nodule converts the iodine into thyroid hormone uncontrollably with no control, none of the usual control mechanism. That's one of the reasons why it's important to engage the attention of a knowledgeable physician. Use a knowledgeable physician when you're thinking about starting a high dose iodine protocol. The reason for that is that they can do the required thyroid labs and exclude the possibility of autonomous thyroid nodule or toxic nodular goiter. Now, the other group of people that will have an adverse side effect from iodine, high dose iodine, is the people with autoimmune thyroid disease. And as I mentioned earlier, we were talking about Graves' hyperthyroidism. That's a form of autoimmune thyroid disease. And in that group, iodine intake, going way back to the 1800s, was continuing all the way to the current day. Iodine is used in that group to inhibit thyroid function. So this is also true for Hashimoto's autoimmune thyroid disease. Those people will also be inhibited by iodine. So in that group, the Hashimoto's group, we will use a lower dose iodine, 225 micrograms of iodine daily instead of the 12.5 milligrams for the autoimmune thyroid Hashimoto's patients. If those patients take high dose iodine, that will suppress their thyroid function, and the TSH will go quite high. That's very disturbing to the primary care physician, the family practitioner, and to the endocrinologist, they'll get very upset. The reason for that is people with autoimmune thyroid disease have lost autoregulation. Normal people, the normal rest of the normal population, they have normal autoregulation, which means they can take high dose iodine. There's a very brief period of 24 to 48 hours where there's suppression of thyroid function by the high dose iodine, and then very promptly they're able to compensate for it and restore normal thyroid function. They do that by downregulating the sodium iodide importer and also the and compensating for that. The compensation is done by these compounds called iodolactones, which is iodine reacting with lipids in the thyrocytes and in the thyroid gland. Just parenthetically, we talked about iodine as a treatment for breast cancer, and the mechanism also involves those very same iodolactones that the breast cancer cells have active transport of iodine. They actually have a sodium iodide importer, which is the little protein machinery, little protein machine that takes up the iodine and concentrates it, and then the iodine is then converted to the 6-iodolactone, which then has anti-cancer activity, actually induces apoptosis within the breast cancer cell. Apoptosis is the medical term for programmed cell death. The doctor who discovered apoptosis received the Nobel Prize in medicine. It's that important. We have cells in our body. We have 1 trillion cells. There's a few million cells every day in our body that are undergoing apoptosis. Why? Because they're becoming senescent, which means they age and they stop functioning properly. This will trigger automatic cell death. It's a program contained in every cell of our body. When the cell ages and no longer function properly, or the other trigger will be mutations in the cell DNA. The DNA is no longer functioning, has too many mutations, can't be repaired. That will trigger programmed cell death. That's what iodine does to the breast cancer cell. It triggers programmed cell death, which is good. It's now considered an adjuvant treatment for breast cancer. And we have a chapter in the book just devoted to all the research showing iodine as a adjuvant, excellent adjuvant for breast cancer treatment. We touched on the safety of iodine. It's safe for the general population. You have to be careful in patients with Hashimoto's. Use a lower dose. The 225 microgram dose has been studied in autoimmune thyroid disease and found to be safe. The other thing that we found is once the autoimmune thyroid patient receives treatment with thyroid hormone, their thyroid pills, with suppression of TSH. Once the TSH is suppressed in those patients, they're on enough thyroid medicine to make them feel good, and they have a suppressed TSH. They're no longer at risk of developing hashitoxicosis from high dose iodine. At that point, it's safe for them to, if they need to, say they have fibrocystic breast disease and they would like to treat that with higher dose iodine, they can do so once the TSH is suppressed.
Wow. I feel like you're part mind reader, because the moment that I had a question like at the tip of my tongue for you, boom, you answered it right away.
Okay, great.
I'm glad that you brought up the other halogens, the bromide and the fluoride, how they kind of compete and they bully with iodine, because that's what I've read through the Iodine Crisis and another book that I have called The Fluoride, the Aging Factor.
Yes.
When I started supplementing with iodine, I did notice some dermabromism, where it would be coming out of my arms, I would get like these weird little pimples. So
Yeah.
I guess I needed to up my salt intake at the time. So actually, before we jumped on this call and I initially reached out to you, you mentioned that you hadn't seen a single case of breast cancer in your clinic within, I think, the previous 5 years, but you also
Yeah.
mentioned you are um, also prescribing testosterone to these women as well.
Yes, yes. When it comes to breast cancer prevention protocol, iodine, of course, is on the top of the list. The other breast cancer preventive that's very effective is testosterone, which and that research has been published in the medical literature. Most of those studies have been done by a, uh, a lady surgeon in Dayton, Ohio, who by the name of Rebecca Glazer, and she's collected all the data. She's for the last 20 years, she's been in active medical practice, treating women, pre and postmenopausal women, with testosterone pellets. She's been using the pellets, and she has collected the data over the years showing a 40% reduction in breast cancer in the women treated with testosterone pellets. There's also similar reports, similar type of research from another doctor by the name of Gary Donowitz, who's also been using pellets for many years, and has similar numbers, similar data, and so the next obvious question is, well, what about the mechanism? Has that been studied in? And so they have breast cancer cell culture models and also xenograft models. Those are the two main ways to study breast cancer. You can study breast cancer cells in culture in a petri dish, and then you can inject the breast cancer cells into mice and other animals. It's usually mice, and then give the mouse different treatments to see if you could cure the cancer. So those it's called preclinical basic science studies. So that research has been done with testosterone, and it shows that testosterone inhibits the stimulatory effect of estrogen on breast cancer cells, and the mechanisms have been worked out, and it's very effective as a breast cancer preventive. The research on testosterone has also given us an explanation of why certain types of synthetic forms of progesterone, which were used in the Women's Health Initiative study in 2002 and 2004, those publications came out in the Journal of the American Medical Association, JAMA, in 2002 and 2004, which showed increased breast cancer when a synthetic version of progesterone was used. And the drug that was used was medroxyprogesterone. They take the human progesterone and add methyl groups. They add, they chemically modify it, so it's now synthetic. There's other 2 or 3 other synthetic versions of progesterone, and they all have testosterone activity in addition to progesterone activity, because the receptors will recognize the synthetic hormones as testosterone. And when it comes to medroxyprogesterone and some of these other ones, it actually blocks the effect of testosterone. And when you block the effect of testosterone, you're blocking the anti-cancer effect of testosterone. And so that is the explanation for the increased breast cancer in women taking these synthetic progestins. It interferes with the anti-cancer effect of testosterone. Mm-hmm. It's interfering with testosterone. And so, that's useful information. Any time we have a greater understanding of historically, the Women's Health Initiative study was made a huge impact on medical science, and also made a huge impact on the general population of women who decided, doctors and women who decided to stop using hormone replacement, because they showed a roughly 20-25% increase in breast cancer in women using hormone replacement. And now we know it was the synthetic progestin. It wasn't the estrogen. It was the synthetic progestin that was the culprit. And we also understand the mechanism. So, that's huge when you have research that shows that and gives us a greater understanding of that. So now the pendulum is swinging back the other way, and we now have articles appearing in the medical literature saying, guys, we were all wrong. There's actually a health benefit for hormone replacement for menopausal women, and women should do it. They can do it safely simply by avoiding these synthetic progestins that were the culprit in the Women's Health Initiative study. And so that's the topic of my next book, which hopefully will come out over the next year, which will be entitled, Doctor, Why Do I Need Hormone Replacement After Menopause? And so, that's a whole book all in itself, which, it would be, when that book comes out, we can do another podcast.
Sure, for sure. It's unfortunate that a lot of this information comes out afterwards, after people have already kind of dealt with the effects of whatever it is that they're taking. In regards to testosterone, I don't want to keep you much longer. I only have 2 more questions for you. The testosterone being anti-cancerous or having an anti-cancer effect, what's the relationship here with estrogen? So would estrogen kind of be elevating too high? I know that there's also, I believe that iodine has an effect on estrogen as well.
Yes, the iodine will serve to reduce the stimulatory effect of estrogen on the breast cells and breast cancer cells. But it even goes beyond that, because the iodine is converted to the iodolactones, which then go to the nuclear receptors and turn off the cancer cell machinery that makes the cell cancer. So, if you listen to Dr. Brownstein, he'll say the iodine makes the cancer cell revert back to a normal cell. And that's what he's talking about. So iodine is very, very important for the health of breast tissue. What was your question again? Something about breast cancer.
Just estrogens or
the estrogen. Right. So yes, now I remember. That's the big question. I mean, when I was a medical student, I did a rotation as an intern after medical school. I was an intern then. I did a rotation on a breast cancer surgery floor. This Dr. Stephen Economo was the breast cancer surgeon, and he would, every morning we'd meet at 7:00 and go on rounds, and in and out of the room, seeing each breast cancer patient before and after surgery. Those are all his patients. They were either waiting for surgery or they had just had surgery. And so we would pop out of the room. We'd be, a group of us, all of his students, residents, fellows, and he loved to ask questions that we couldn't answer. So it came to be my turn, and he pulled me out by name. He pointed me out by name and asked me the question, does estrogen cause breast cancer? This was in, 1976. So, I mean, I had just finished medical school. I had studied, what I was supposed to study. And I knew that estrogen stimulated the growth of breast cells. So that's what I said. I said, estrogen stimulates the growth of breast tissue. So anything that stimulates growth will also cause cancer. And that's partially true and partially wrong. I mean, it's partially true. It's true. It does. Estrogen will stimulate growth, but the question is more complicated than that. And I'll refer you to the second arm of the Women's Health Initiative study, which was published in 2004. And they had 5,000 women. They'd all had hysterectomies, so they didn't need that really bad progestin culprit medication. Instead, they took only the estrogen part of the program, which was, in those days, they used Premarin, which comes from a pregnant horse. Horses are natural. It's not human. I mean, part of it was human, part of it was from a horse. And what they found was they had a roughly 23% reduction in breast cancer in the women taking the estrogen, which was unbelievable. The people who did the study couldn't believe it. None of the researchers at the time could believe it, but that's what they got. And not only that, on each subsequent year follow-up study, they published the 11-year follow-up, which was in 2016, 17. And they still had a 25 to 30% reduction in breast cancer and reduction in mortality in the women who took the estrogen. So, and if you look back in the history of medicine, back in the 1930s and 1940s, 1950s, they actually used high-dose estrogen to treat breast cancer. Believe it or not, that's what they used. And they actually got a remission from metastatic breast cancer in 30% of the case, not in everybody, but 30%. They would see a remission in metastatic disease. And so this is going to be in my new book, by the way. And we talk about this a little bit in the newsletter on the testosterone for breast cancer. And what they found was the researcher is a PhD. His name is Craig Jordan, V. Craig Jordan, who actually invented tamoxifen, which is one of the widely used breast cancer drugs. It's a SERM, a selective estrogen receptor modulator. But anyway, he had PhD students over many years in multiple labs doing research on, again, preclinical studies, breast cancer cells in culture, and also animal xenografts. And what he found was if they estrogen deprive the animal or the cell culture, either for a certain amount of time. In humans, it's 5 years. So you can do human studies where you estrogen deprive the human. If the human or the animal is estrogen deprived for a number of years, when you give them back the estrogen will now cause apoptosis of the breast cancer cells. And that's where that's how they're able to get the 30% remission in the metastatic breast cancer back in the early days when they were using estrogen to treat metastatic breast cancer. And that explains the results from the Women's Health Initiative study from 2004, because those women were about 10 years out from menopause. Instead of being 50 years of age and starting treatment with hormone replacement at the time of menopause, onset of menopause, these women were about 60 years of age on average, if you look at the numbers in the study. So they were about 10 years out. They had been estrogen deprived for about 10 years. And now when you give them estrogen will then kill any little occult breast cancers that they have. We know that women, the average, if you study women, which was done in Finland, they did a study where of 100 consecutive women who died in car accidents, and they did histology sectioning of breast tissue in the postmortem in all of these women after they died in their car accident. what they found was 20% harbored occult breast cancer. And a lot of it is called DCIS, which is ductal carcinoma in situ. And we discussed that in the book. But so what happens in the Women's Health Initiative study was by giving them estrogen after being estrogen deprived, the estrogen is now a breast cancer treatment. It kills the little occult breast cancers that they had that would have developed into breast cancer over the next few years. And that's why there was a 23% reduction in breast cancer in that group, which persisted even on the later follow-ups. So, if you look at Dr. Jordan's research on this, he connects all the dots and connects everything together, and shows that estrogen deprivation is the prerequisite for estrogen turning into a cure for cancer. So estrogen, if you have an occult cancer in a woman, in a female, in a woman, and you give her estrogen, that will make the cancer grow. It's a breast cancer. Breast cancer. One of the hallmarks of cancer is the cancer cells will make their own growth factors and make. So what breast cancer does is it recruits other cells, the fibroblasts in the microenvironment of the breast tissue, to manufacture estrogen. So the breast cancer causes production of its own growth factor, estrogen. So if you give estrogen to women with breast cancer, that will stimulate the growth. It's already, that's the growth factor. It's already being used as a growth factor. Give more estrogen, the cancer's happy. It loves estrogen. There are other growth factors involved, but that's the big one that's the main one for breast cancer. The other one is epidermal growth factor. That's human epidermal growth factor is HER positive. Estrogen is sort of like a double-edged sword.
Yeah.
It's the major growth factor for breast cancer, but if you deprive the breast cancer cells of estrogen, then this is what the research shows: the estrogen receptors in the breast cancer cells are upregulated, and it's sort of like the thyroid needs iodine. It'll upregulate the sodium iodide importer with iodine deficiency. Well, with estrogen deficiency, the breast cancer does something similar. It upregulates the estrogen receptors. Instead of having, for example, 10 estrogen receptors per millimeter, it'll have 1,000 or 1,000,000 per millimeter of the outer membrane. It just upregulates not only the receptors, but also the machinery of using estrogen as a growth factor. So the starved for estrogen breast cancer cell, once it gets estrogen again, it's sort of like plugging your lamp into, instead of a 110, you're plugging it into a 220. What's going to happen to the light bulb? It's going to pop because it's too much electricity. So it's almost like electrocuting that cell. It's too much stimulation from estrogen, because now it's just sucking up all that estrogen, and the estrogen goes directly to the mitochondria and induces mitochondrial apoptosis. We talked about programmed cell death. That's all in the mitochondria. The programmed cell death is a mitochondrial function. So the estrogen goes right to the mitochondria and tells it it's time for programmed cell death.
So if I'm understanding that correctly, the estrogen would be beneficial post-menopause, but say, for instance, if a woman in her 20s or 30s had breast cancer, then giving her more would make it just proliferate even more.
Right, exactly. So if somebody has breast cancer, you don't give them estrogen. That's going to stimulate the breast. It's going to, the breast cancer is already making its own estrogen. The best the standard treatment now is they have these medications like exemestane, letrozole, and these are aromatase inhibitors that prevent the production of estrogen locally by the cancer. the cancer is trying to make its own estrogen. So these drugs prevent the breast cancer cells from making estrogen as a growth factor for itself. And those drugs work great. They stop working after about 5 years. And when that happens, now the cancer cells have been estrogen deprived for 5 years. Now you can give estrogen, and that kills the metastatic disease after the patient's been deprived. That's V. Craig Jordan's research, and he's given published a number of studies and given lectures on it. That's directly from his work. So that's why. So estrogen, which we'll get into it in the next book. Estrogen is very important for overall health of women. Over the age of 50, after menopause, estrogen levels decline, and that begins the onset of various degenerative diseases. They develop arthritis in the joints because the cartilage has estrogen receptors and needs estrogen. Cognitive dysfunction, the brain needs estrogen. They develop heart disease, heart needs estrogen. They develop osteoporosis. Maintaining good bone density requires estrogen. Estrogen is now FDA approved as a treatment for osteoporosis, and it's now accepted as first-line treatment for maintaining good bone density. It goes on and on. There's more, but estrogen. It's sort of like thyroid. Iodine. It's needed for life. It's essential. We need estrogen, testosterone. We need to have good hormone levels to maintain a good quality of life as we get older beyond the age of 50.
Mm-hmm. Yeah, vibrant health. Well, Dr. Dash, I am so grateful that you could join me on this one, brother. I really wanted to put something out for Breast Cancer Awareness Month, considering I read in the Iodine Crisis that I didn't know this before, but Breast Cancer Awareness Month is actually trademarked, I believe, by AstraZeneca. So that should be a little bit of a red flag. And I believe that this type of information, the fact that you state like iodine can be curative for breast cancer and fibrocystic breast disease, I think that's huge. And I really want to get this information into the hands of the people that need it the most. So I'm very grateful for your time, brother. Now, last question I have for you is how would people be able to work with you?
My website is jeffrey-md.com. jeffrey-md.com, spelled DACH, and you can go to my website. There's a contact page. Just click on the contact page. You'll get the address and phone number. We're located in Davie on Griffin, 7450 Griffin in Davie, and you can go to Amazon. You look at my books. Let's see, there we go. Natural Thyroid Toolkit. Finally got that.
Yeah.
The image on the cover. This is what your thyroid looks like. These little follicles, these little pink areas. That's the thyroid globulin inside the follicle, and the cells around it in the circle. Those are the thyrocytes that produce the protein, the thyroid globulin in the middle. So this pink material, that's proteinaceous material that will become thyroid hormone and is then released as thyroid hormone. Mm-hmm. The white areas are artifacts. That's just where the protein just kind of pulls away from the slide. Awesome. So just if you put in my name, Jeffrey-MD, JEFFREYDACH, into any search engine, my website will pop up, and you can always the phone number will pop up. You can always find us. We have a lot of articles on the internet, so it's easy to find us. Mm-hmm.
Yeah, there's tons and tons of articles. It's like I bought the Natural Thyroid Toolkit book, and then I'm like, oh my God, there's so much more though. There's vitamins.
Yes.
So it's awesome.
So, thank you so much for having me, James. And I wish you the best. Keep up all the good work, and we'll look forward to the next one.
Round 2. It's been a pleasure, brother. Thank you so much.
We'll talk later. Have a nice evening.
You too. God bless.
God bless.